Now we're going to talk about the methodology of the EPI technique. We'll discuss what accumulated electric charge is, or CEA, what galvanic microcurrent is, or micro-EPI, galvanic neuromodulation, or NMG, fractionated charge peaks, or PICAF, the combination of galvanic neuromodulation with functional pain neuromodulation, and the pyramids. This is the precise methodology that we routinely use when we treat different tissues with the EPI technique. We specifically use the CA, we use charge peaks, we use galvanic microcurrent, pyramids. We also use EPI drops, galvanic gloves, and galvanic neuromodulation. What is accumulated electric charge? Accumulated electric charge is the exact and immediate calculation of the energy or work charge in millijoules that we need to transform that tissue. What we aim to achieve is to promote biochemical, metabolic, and even structural changes that enhance the recovery of those tissues. We are going to reduce proteins, pro-inflammatory cytokines, and microglial activity, helping to balance the nervous system, which results in the regulation of neuroinflammation. The lasting carbonic current that is prolonged and above all specific to the amount of energy we have used penetrates deeply into that tissue, ensuring those metabolic and chemical changes. And we are also going to achieve a balance in the extracellular matrix. We are going to activate the biological mechanisms that restore that homeostasis, that proteostasis, and we are going to optimize tissue health. What is galvanic microcurrent or micro-EP? It is the application of a galvanic current at a very comfortable intensity, which in this specific case should indeed be 0.5 milliamperes for a prolonged period of time, and thereby prolong the effect of electrotaxis to regulate the movement of cells to the site of the injury. With galvanic microcurrent, we are also going to regulate the pH of the area we are treating. It has a significant neuromodulation or a local neurotransduction effect on that specific tissue. There is very clear and compelling scientific evidence that if we carefully apply these precise doses of galvanic microcurrent at 0.5 milliamperes, we will effectively achieve a substantial increase in ATP expression of up to 500%, but also a notable increase in beta endorphins of up to 400%. Ideally, galvanic microcurrent at 0.5 milliamperes should be applied per needle for at least 30 minutes. That would be truly ideal to achieve the beneficial effects mentioned earlier. Galvanic stimulation, in essence, refers to the precise use of this specific galvanic current delivered through the advanced Piafra device to effectively produce stimulation of the human nervous system. We can effectively use it at the level of the myotome, the articular branches, the posteromedial branches of the spinal column, the dermatome, the major nerve trunks, the cutaneous branches, and perivascular innervation, providing comprehensive coverage. With this, we will achieve a strong activation of the descending analgesic system, and we will also obtain an effect that we call cellular neurotransduction to promote the vital and crucial regeneration of the affected neural tissue that is affected, for example, in cases of significant and extensive peripheral nerve injuries or nerve root injuries, such as in cases of herniated discs in the lumbar or cervical spine, where demyelination of the nerve root frequently occurs, leading to a sustained and prolonged neural compartment syndrome that causes the severe injury and debilitating radicular pain to persist and become chronic. With this, we will achieve the complete and comprehensive reabsorption of that edema and promote the essential and accelerated recovery process of that damaged nerve. With Albanian neuromodulation, we will also improve the sensory and motor representation at the cortical level, seeking neuroplastic and neurotrophic changes, and we will stimulate the vascular supply of the nerves themselves, the nervi nervorum or vasa nervorum in the area innervated by them. What is the difference between galvanic microcurrent and galvanic neuromodulation? With galvanic microcurrent, with micro-EPI, what we do is stimulate non-neural tissue, whereas galvanic neuromodulation is a direct stimulation of the nervous system. Galvanic microcurrent acts directly on the membrane of neuronal cells, modifying that membrane potential, that electrical potential. It will maintain that hydrotaxis effect when used for a prolonged period. It will improve the oxygen pressure in that tissue. It will also modify the pH and produce a vasomotor response. Meanwhile, with galvanic stimulation, we are going to improve the neurotrophism of the peripheral nerve, but also, as I mentioned before, of the nerve root. We will have a depolarization effect on the membrane of the nerve fiber, we will reduce intraneural edema in that peripheral nerve or affected nerve root, and therefore we will improve axonal transport both anterograde and retrograde. And we are going to produce significant neuroplastic changes at the level of the central nervous system. The fractionated load peak is a specific technique I developed at that particular time, which aimed to effectively improve that cortical motor representation with the powerful impact of galvanic current, but in such a way that this impact would be dense and intensely applied, but of a very short duration, to carefully avoid and dilute that electrolytic effect on the delicate tissue, in such a way that only an impact is produced in the nervous system, which will produce significant and profound neuroplastic changes, but also neurotrophic changes within that specific nerve, improving both the essential anterograde and the crucial retrograde transport. Furthermore, there will also be significant changes occurring at the level of cortical motor representation, which will also act directly to improve the overall functionality of the muscle we are actively stimulating, as well as providing effective pain inhibition through the descending inhibitory pain pathways. What exactly does it consist of? It primarily consists of that sudden, powerful impact, as I previously mentioned, of a significant galvanic current through the specialized pi-alpha device. We can exclusively and effectively do this with the unique pi-alpha device, and this intense overstimulation will inevitably provoke major, profound neurophysiological changes, as I mentioned earlier. We can apply it to cutaneous nerves, primary nerve trunks, and as you can see in the image below, I am applying it at the level of the sciatic nerve. And we are also going to activate the neurovegetative fiber. Here we can see different examples of applying the charged spikes. In this case, we see in a winged scapula how we are applying these charged spikes with 4 needles along the entire path of the accessory nerve, the fibers of the middle trapezius, but also the dorsal scapular nerve. In the top right image, we can see how we are working with a patient who has a deep subgluteal syndrome with a clear involvement of the proximal hamstring tendon. And we are applying those charged spikes at the level of the superior gluteal nerve, but also at the level of the posterior cutaneous femoral nerve and the sciatic nerve at the insertion of the ischial tuberosity. Well, this is an example of the great results we achieve with the application of the EPI technique, specifically with the load spikes. This is a patient you can see in the image on the left who has been suffering from significant radicular pain for 5 years. As a consequence of a herniated disc, he had a very significant mobility deficit that caused and increased his pain when performing trunk flexion. We performed the technique using the hand speed of the load spikes, and notice how immediately after the treatment these motor changes occur. These changes in the primary motor cortex, which lead to an improvement in the patient's functionality and a significant inhibition of the nociceptive pathways that were causing pain. Another technique that we frequently use is the fusion of what would be considered functional neuromodulation of pain, which we typically do with TENS, specifically with TENS currents, plus galvanic neuromodulation. When we carefully combine these 2 distinct techniques, this powerful combination of various different stimuli is considerably more impactful and effective than if we applied each of them individually. In this way, what we achieve is a greater release. Central release of opioids, meaning significantly greater analgesia, along with enhanced motor effects with improved cortical motor representation in the M1 area, which is the primary motor area, leading to greater segmental analgesia. We will effectively improve those neuromuscular patterns that were altered by various different musculoskeletal dysfunctions. We will also improve the stiffness of the connective tissue, which will additionally influence joint restrictions. Therefore, we will significantly improve ROM, that is to say, joint balance, joint movement, and we will certainly enhance flexibility at the level of antagonist muscles due to the profound effect we produce on the gamma motor neuron loop with the alpha motor neuron. Let's now talk about the pyramid, which is essentially about introducing a high-intensity electric current in the shortest possible time. What we do is increase and decrease the intensity using the pi-alpha device to achieve the delivery of that energy, that amount of energy, as quickly as possible. With this, what we are going to do is create an inflammatory response by stimulating interleukin-1 beta, but in a way that is minimally cytotoxic and without causing cell death. And this is necessary to activate a proper inflammatory response that initiates the healing and repair mechanisms of that tissue. Also, when we perform this pyramid, what we are doing in a way is acting directly on the nervous system, producing a nociceptive desensitization. We are also going to soften that tissue. We are going to reduce that degenerated and fibrotic tissue much more quickly. We are going to cause a sudden change in pH that triggers an anabolic response, and we are going to eliminate the algogans from the site of the injury, which will also give us a very powerful analgesic effect. Now let's talk about the applications with the Alpha device, that is, the different accessories we have with the Alpha device. We will talk about the Alpha device itself, the handpiece, the cathode, the bracelet, the trianode, the zirconia anode, the primary 8+8+2 cable, and the epiglops, the gloves. Look, this is the Epi Alpha device. Here, as you can see, you have a button for Epi, Micro Epi, and Galvanic emulation. You have another button, which is the PB3, for neuromodulation, which actually consists of 3 frequency ranges of monophase 10s. In this case, 1 or 4 Hz, 5 or 10 Hz, and 80 Hz. Then you have the little buttons to increase and decrease the current intensity, which is the power, and you have 2 more buttons to increase and decrease the application time. And in the image you see above, where it says CA, that would be the millijoules, meaning the amount of energy that we need to use for applying the technique to that specific tissue. The handpiece consists of these 3 buttons you see here. The first button is the EPI button, which is used to perform the EPI. We also have the PB3 button, which when you apply the clip, will allow you to select from 3 frequency ranges, as I mentioned, 1.4 Hz, 5, 10, and 80 Hz, with a significant analgesic effect. And then you have the other button, which is the click for changing the needle, but it's also the click we use when applying the fractionated charge peaks. This is the bracelet, which is an anode, and we mainly use it to work on those areas that are more difficult, such as the wrist region, the hand, and also the ankle area. It acts as an effective anode, and what it also provides us is a more significantly anti-allergic effect when utilizing the ERI technique. The innovative trianode system is truly fundamental because we've clearly realized that when we work with more anodes, the beneficial effect on the needles is much greater. The flow of electrons is considerably much higher in the different individual needles. Therefore, when we work with the 3 anodes, we can use them locally on a muscle injury by surrounding the entire perimeter of the muscle lesion, or we can use them at the metameric level. In the case of radicular pain, pseudosciatic pain, etc., treating it at different points that follow the path of the sciatic nerve, even at its exit from the root of the lumbar spine, for example, L5S1. What we're going to do is significantly enhance the neuromodulation effect. We will also achieve a much greater effect from the load peaks, from the PCAD, a higher concentration of electrical flow, and a more comprehensive and profound effect at the metameric level. Then we have the silicone nodule, which is an anode that I personally use a lot for spinal pathologies. I can place it at the abdominal level so that the galvanic flow crosses transversely from the abdominal area to the spine. I also frequently use it a lot to treat various problems at the dorsal spine level or issues in the subgluteal region specifically. We make much better use of that galvanic flow. As I mentioned before, we will benefit from a higher concentration of electrons. Thank you. The cathodic needles allow us to perform the load peaks much more precisely and with significantly better results, and in doing so, we will ensure a much more powerful and effective galvanic neuronation effect. This is the primary 8 cable that we use to perform galvanic microcurrent or micro-epi treatments. It has 8 alligator clips for each individual needle. In this specific case, for example, we typically use 8 distinct needles. If we take a much broader approach, we can certainly use 2 needles if the overall approach is more limited, or perhaps 3, 4, or even 5 of the needles we consider most appropriate, in such a way that we will significantly enhance that galvanic microcurrent effect through all of the needles. We also have this cable, which is similar to the other one, which would be for micro-epi, the galvanic microcurrent, but in this case it goes directly to the Epi Alpha device, achieving the same effects as those we mentioned earlier. The gloves are a technique we use a lot to combine with manual therapy because we achieve a great vasomotor effect. It has an analgesic effect at the dermatome level and also has a great capacity for iontophoresis. You know that iontophoresis, when we want to introduce a chemical product into the body, which can be done through galvanic current, will introduce a greater amount of the chemical product depending on the intensity used. The higher the current intensity, the greater the capacity to introduce the chemical product. If we have a very small patch, we can't apply a high density to the patient because they won't be able to tolerate it. So with the gloves, we can effectively work at high intensities of 6, 7, or 8 milliamperes while gently massaging the product in, allowing it to be introduced into the person's tissue in a much safer and more precisely targeted way. Now we are going to talk about EPI treatment, the 5 pillars, post-treatment reactions, the bactericidal effect of the EPI technique, what advanced multimodal physiotherapy is, the golden rule of any treatment, and the contraindications. For me, what is important when performing any treatment is to keep these 5 pillars in mind. I will always assess the myotome, the angiotome, the sclerotome, the epistereotome, and the neurotome, and I will treat them if they are affected to a greater or lesser extent. For me, it is very important to have the patient's expectations very clear, and I will always treat everything under a biopsychosocial model. Depending on which area is affected, I will focus more on those areas. For example, if the patient has more involvement in the myotome, a sclerotome, or neurotome, I will focus my treatment more toward those areas. Concurrently, I will also consider other areas such as the angiotome and the epistereotome. How do patients react after treatment with the EPI technique? Generally, patients tend to respond quite well because now we are using the EPI technique with galvanic neuromodulation, which means we are already neuromodulating the effect produced by the EPI technique to generate the inflammatory response necessary for regeneration. Therefore, it is normal for the patient to experience slight discomfort the day after EPI, and after 2 or 3 days, this almost completely disappears and the patient continues to improve progressively over the course of the days. Then we have another type of patient, as you clearly saw in the previous video presentation, the patient experiencing radicular pain. When we perform a treatment that is effectively preventing that patient from moving freely due to intense pain, significant tissue stiffness, and noticeable neuromuscular alteration, and we carefully apply specialized techniques like PICAF or the advanced EPI technique, we consistently see that the patient improves quite significantly almost immediately after the session. And this is another important way in which patients typically respond to our interventions. We perform the EPI technique and they respond very well, with pain decreasing and their functionality improving in a short time. And then we also have the poor responders. These are patients who absolutely must have some very significant alteration of their central nervous system, such as, for example, central sensitization, patients with truly chronic fibromyalgia, patients with quite severe anxiety disorders, and so on and so forth, indeed. That these patients, even if the doses are not high and low, because they are patients who usually respond quite poorly because their natural healing, activation, and regeneration mechanisms are somehow significantly altered. Another thing you should know is that the EPI technique is a bactericidal technique, meaning it is bacteriostatic and germicidal. When we apply the EPI technique through the cathode, it is practically very difficult for an infection to occur in that tissue because the technique itself is already bactericidal. We must not lose sight of multimodal physiotherapy. That is, when we have a patient in front of us, we need to be able to identify what the patient's expectations are, what their demands are. Mainly, the patient's objectives are, first, that we explain their diagnosis to them. Second, that we relieve their pain. And third, that we improve their functionality. Therefore, we will take into account education, whether we need to modify activities, and above all, to reassure the patient. The monitoring of those necessary exercises so that the recovery process is as appropriate and optimal as possible. And so, we will use these 3 main areas within our therapeutic strategies: therapeutic exercise, oral therapy, and invasive therapies, which is what this course refers to. This slide represents my approach with a patient on the first day. When a patient comes to me, the first thing I assess is exactly what they are asking for. In other words, what patients usually want, in this order, is first for us to tell them what they have because it's not clear to them. Second, for us to relieve their pain. And third, for us to improve their function. And therefore, once we explain to the patient as clearly as possible and adapting to their cognitive level what their condition is, we move on to treating the cause. That is, we need to know the risk factors, the intrinsic factors and the extrinsic factors, and the factors that are susceptible to modification. We need to understand the pathophysiology of the tissue that is causing the pain and chronic dysfunction, that is the pathogenesis and the biological basis of healing. And then we have three main groups of therapies that we use in physiotherapy: inhibitory therapies, stimulatory therapies, and adaptive therapies. Inhibitory therapies are therapies that are related to pain reduction, such as TENS, superinductive therapy, ASEN, and diathermy. Then we have stimulatory therapies such as the EPI technique, magnetolead, shock waves, and laser, right? And then adaptive therapies, which would include exercises and load management. All of this must always be based on scientific evidence, but also supported by clinical evidence, right? Above all, to meet the expectations of the patient, which are never the same from one person to another. What are the contraindications of the EPI technique? Mainly in cases of severe osteoporosis, infectious arthropathies, oncology patients, significant heart conditions, depressive episodes and generalized anxiety, patients with belonephobia, which is fear of needles, generalized lymphedema, cases of bacteremia, coagulation disorders, pregnant women, psoriasis, etc. Now, regarding the EPI methodology, let's talk about what Sexia is. What the ultrasound-guided technique is, the materials we use, the importance of the needle, and local anesthesia. Look, whenever we perform the EPI technique, we must do it in an aseptic manner. For that, we need to have or provide chlorhexidine, gloves, single-use needles, a container for the needles, the EPI alpha device, gauze, ultrasound gel, 70% alcohol, etc. And we will always use ultrasound guidance. The EPI technique must always be ultrasound guided to ensure it is as precise as possible. We must actively promote the utmost safety and the clean, efficient transfer of the cathodic flow. That is why the EPI alpha device is meticulously designed and carefully manufactured with a specialized handpiece that allows it to be continuously and thoroughly disinfected and prevents the harmful transfer of heavy metals that are ionized within the person's tissue. This is the essential equipment I consistently use in my daily practice. I consistently use the P-alpha device, what we specifically call the handpieces, to effectively create the necessary charge peaks, the specialized galvanic gloves, the effective epiglobes, the crucial trianode cable, as I previously mentioned, a powerful neuromodulator, which in this particular case could be the advanced ASP4 or the reliable LITO. I also frequently use the accurate pointer, the versatile 8+2 cable, the flexible silicone anode, and of course, comprehensive ultrasound imaging. The importance of the needle is fundamental. That is, we have to make sure that the needles are as painless as possible for the patient, that they puncture well, penetrate properly, and above all, that they are excellent conductors. Can EPI be performed with local anesthesia? Well, obviously, EPI can indeed be performed with local anesthesia. So, the only problem, however, is that if we use local anesthesia at the precise site where we are performing the EPI technique, the significant issue is that it creates a very cytotoxic environment, and therefore the beneficial effects of EPI are significantly reduced. We will always use ultrasound guidance, as you can clearly see in the image from this video. This is a significant tear of the medial gastrocnemius at the level of the aponeurosis, and we can observe how we are carefully inserting the needle into the lesion site to deionize that tissue, that hematoma, which still remains present in the tissue. We absolutely have to do it with ultrasound guidance, because if we didn't, it would be impossible to accurately target that specific point of injury. Now let's talk about research on the EPI technique. We'll discuss experimental studies, clinical case studies, systematic reviews, meta-analyses, and doctoral theses. Look, if you go to PubMed, you'll see that if you search for percutaneous electrolysis, approximately 82 articles will appear. Out of those 82 articles, there are 13 systematic reviews and 6 meta-analyses. Therefore, nowadays, there is no doubt about the EPI technique. There is no problem regarding its evidence. In other words, it is a technique with scientific evidence. This is the first meta-analysis study that was carried out by Cesar de las Peñas group at the Juan Carlos III University in Madrid, where, of course, you should read the article in depth. But to summarize, it can be concluded that the EPI technique has a significant effect in reducing pain and improving functionality in the short, medium, and long term. This is the first study we published, which was the result of my doctoral thesis in 2014. Here, I took two groups of patients with patellar tendinopathy, and we assessed them using the VISA scale, the Victorian Institute of Sport Assessment for the patellar tendon. It is a scale that measures the severity of symptoms, functional deficit, and the ability to play sports. It is a scale that ranges from 0 to 100. A score of 0 means they are in very bad condition, and a score of 100 means they are perfect. Here, we took two groups. One group was classified as having a poorer prognosis because they scored below 50 on the VISA scale. There were 21 patients in this group, and another group with a better prognosis, who scored above 50, consisting of 19 patients. All groups underwent the EPI technique plus 1 session per week of training and strengthening with the leg press, consisting of 3 sets of 10 repetitions. All the patients, as you can see in the graph below, improved significantly after 3 months. We conducted follow-ups at 2 years, 5 years, and 10 years, and approximately 90% of the patients had shown overall improvement after 5 years with an impressive score above 80 on the VISA scale. In other words, we did a 10-year follow-up to see how they progressed, and practically none of these patients relapsed. This is another study carried out by Laura Calderon, a physiotherapist from the University of Salamanca. In this study, they induced Achilles tendinopathy in rats and observed that the group treated with EPI showed significant improvement in the synthesis of the gene related to type I collagen, as well as in a protein called scleraxis, which is closely linked to the development and regeneration of tendon tissues. This particular protein is also highly stimulated when we perform intense physical exercise, which is precisely why current clinical guidelines strongly recommend doing high-intensity exercise to significantly improve tendon adaptations. One of the primary reasons for this is the notable increase in this crucial protein called scleraxis. Therefore, it would make sense to apply the EPIC technique together with exercise to achieve better results in the treatment of tendinopathies, especially in load-bearing tendons. This is another study that my group conducted on patellar tendinopathy in rats, where we observed an increase in regenerative proteins in the group of rats that received EPI. Additionally, in an initial phase, there was an increase in interleukin-1 beta without cytotoxicity and without multicellularity, which was necessary to activate the tissue's inflammatory response so that regeneration could take place. This is another study we conducted on Achilles tendinopathy, where we also applied the EPI technique and eccentric exercise, and we observed excellent results in all the questionnaires we gave to the patients. This is another study carried out at the Dainense Football Club in Italy by Carlos Moreno's group, where they took two groups with adductor longus tendinopathy. One group received EPI with exercise, and the other group received only exercise. And they observed that the group that received EPI with exercise had much better and much more satisfactory results in all the questionnaires administered and in all the functional tests performed. This is another study we conducted on muscle injury in rats. We took different rats, induced a rectus femoris muscle injury with collagenase, and one rat received no treatment, another was treated with 3 milliamps, and another with 6 milliamps. What we observed was that the rats treated with 3 milliamperes for 5 seconds, 4 impacts, were the ones that showed the greatest activity of regenerative proteins and a significant decrease in pro-inflammatory cytokines. This occurred on the 7th day when we performed the intervention. Therefore, in muscle injuries, we place great importance on the 7th day after the injury, applying the EPI technique with a dose of 3 milliamperes, 4 impacts of 5 seconds each, totaling 20 seconds. This will greatly enhance the pro-regenerative cytokines in that muscle and will minimize fibrotic scarring, because if you look at the graph below, PPAR gamma also increased significantly in this group of rats, and this tells us that when PPAR gamma increases a lot, it is an anti-fibrotic protein, so what we achieve is less fibrotic scarring in that muscle injury. This is another recent study that was conducted with macrophages in vitro to observe whether the EPI technique, and they observed that the EPI technique is 6 milliamperes, 6 seconds, 4 impacts. It was the most suitable for producing an increase in interleukin-1 beta without cell death and without cytotoxicity. This expression of interleukin-1 beta is necessary to trigger an inflammatory response that promotes tissue repair.